Hi, I'm Brad Power, and I'd like to introduce Sandra Valladares. Sandra is the leader of the Cancer Patient Lab breast cancer community, and she's also an expert in diagnostics. And she got to know our guest speaker today, Giordano Botta, in her previous professional work, and she will introduce him and moderate the session today.
Thank you very much, Brad. I'm thrilled to be moderating this important conversation about how polygenic risk score is transforming cancer prevention and early detection, which are the most effective strategies to reduce cancer mortality worldwide. And well, Giordano, thank you very much for joining us. It's my great pleasure to introduce you all our speaker, Dr. Giordano Botta, who is the CEO and co-founder of Allelica. Dr. Giordano Botta is a molecular biologist with a PhD in public health from the University of Oxford, dedicated to helping physicians prevent most common diseases through precision medicine. As CEO and co-founder of Allelica, he has pioneered the integration of multi-ancestry polygenic risk score into clinical practice, empowering doctors to identify individuals at high risk of cancer and cardiovascular disease before symptoms appear. His research has been published in leading journals, and he is the inventor of 4 patents. Today, Allelica's technology enables more precise genomic risk stratification, advancing equitable precision medicine, and reducing morbidity and mortality from the most common diseases. Please join me on welcoming Dr. Giordano Botta, who is going to talk about beyond single gene mutations using polygenic risk scores and how to improve cancer prevention. Thank you very much, Giordano.
Thank you, Sandra. Big pleasure to be here and present our work. And I'm going to share some slides so to give you high level description and understanding of the concept also behind our work and our technology. So we founded the company in 2018 really to reduce the burden and deaths of common disease through precision medicine. So the big thing is to prevent common cancer. So the cancer that affect the majority of people. And these diseases, they really take a lot of time to develop. So when they manifest is really the tip of the iceberg, because we know that they can take also many years, even decades to develop. And so since there is a big genetic component behind common cancers, we thought, okay, should be possible to develop genetic tests that can identify individuals that need to be screened and where can be possible to detect the cancer as early as possible. But how this was possible? So why this innovation was possible since less than 10 years ago? Because of the availability of very large biobanks. So this completely changed the landscape, because now we have, for example, the UK biobank, the All of Us in the US, the Japan biobank, FinGen in Finland, that they have around 500,000, 200,000 people that have been followed up for more than 10 years with also the genomics data. So now we have clinical and genetics data together that allow us to develop and validate predictive modeling. So I would like just to show you this cartoon to let you understand the difference between the traditional genetic testing that is called monogenic test, that is based on single genes, so identifying mutations that are considered to be kind of errors in our genome, but they're very rare, but with a very strong effect, compared to the polygenic approach. Polygenic means understanding and assessing multiple genes, but also multiple variations in between genes, because they regulate the expression of different genes. So this one can be considered the genome, our genome, and then we can identify, for example, the mutation. So this is the single gene mutation, the traditional genomic testing. For example, the BRCA mutation that is very well known, so that that women with a BRCA mutation, they have an increased risk of breast cancer, for example, or men for prostate cancer. And so they have to be screened in a certain manner. But then what we can do is to identify the effect of several variations scattered, distributed across the genome, each with a very small effect. But then when we combine all these effects, so this, as you can see, is the list of variants that we use to build this polygenic rescore. So you can see this is the effect of each of those variations, and this can be, so this score can be made from anything between like, a few hundreds, thousand to millions of genetic variants in these scores. So when we combine all this variation and we assess the presence of this variation in a population, we see that are normally distributed. So imagine that these are, the score, so from, the score of 1 to 100, because we can transform in percentiles, and this is the number of people that they have this score. So you can see that there are many people with an average polygenic rescore and few people with a high or low polygenic rescore. So what can we do next? We can identify the risk conferred by each percentile. So imagine the score from 1 to 100, and then we assess the risk conferred by each of the score. And then we can identify also when a certain risk threshold that is already considered to be actionable by the guidelines, so for example, the twofold increased risk or the 20% lifetime risk for breast cancer, is reached. So in this case, we can identify a tail of the distribution where we have this increased risk. And so this is like the initial concept of polygenic rescore. So you see, it's not like a single mutation, but it's a continuum of risk from very low risk to high risk. And then we need to put threshold to identify who are those at elevated risk. And this threshold is based on what the guidelines already tell us. So if they tell us, for example, the 20% lifetime risk is considered to be high, we identify when women they get to this 20% lifetime risk. But then we need to be very careful when we apply this score in a population because of the diversity, the genetic diversity of multiple ancestries. So ancestry is a concept in genetics that describes the, let's say, where our genomes came from in the past. If there was like, from an African origin, from more European origin, or East Asian and South Asian. And then we need to be careful because when we apply this score to different population, we have the distribution that are shifted. So if we identify just one threshold, we cannot reliably identify risk. In fact, we can overestimate or underestimate risk. So it's very important to align all this distribution. There are some, statistical approaches that can be used to align. But then after we align this distribution, we need to calculate the effect, so the risk conferred by each of those scores that I showed before in each of those ancestry. So as you can see here, we have validated the predictive performance in each ancestry. And then we also assess the calibration, because also in a risk model, it's so important to assess the calibration of the model. So the calibration means that if a model tells us 20% lifetime risk is indeed a 20% lifetime risk, or maybe it's 30%, 10%, because it's not well calibrated in that particular population. So this is like, the validation and calibration assessment that we have performed to be sure that these scores can be applied to anyone, regardless of, their ancestry or their ethnicity. So now I'll jump in some clinical application of polygenic rescore. I want to start with breast cancer because we know that breast cancer is so common, and there are already in place some screening method to identify women at high risk based on age, mutation carrier status, or like BRCA carrier, or also based on risk models such as the Thyrocusic and the CAN risk that they integrate multiple risk factors. But the problem is that, around 7% of cancer happen in women below the age of 40. And we know the mammogram, the recommendation is to start mammogram at 40. So there are 7% of cases that cannot be captured by, the standard screening. And then also less than 10% of cases have a pathogenic mutation. So for example, BRCA1, 2, PALP2, CHEK2. So these are single gene mutation. So the single gene mutation, this monogenic approach is really helpful, but it's limited because just 10% of cases are identified. And then another big problem is that around 50% of women have high breast density. And this is a problem because the mammogram has not the same predictive performance, or also the same detection performance that has in women with without high breast density. So this means that the sensitivity decreases to up to 50%, below 50%. So we really have to use additional and alternative method to identify the breast cancer early in women with high breast density. And this is something even, let's say, is a recent problem that was highlighted because of the FDA mandate to return the breast density after each mammogram, because then you can really see the density of a woman, if the mammogram was reliable or not, because before we couldn't really rely on mammogram for women with high breast density. So what we did is we developed a polygenic risk score for breast cancer, and we developed it using multiple biobanks, by this large prospective data set, and we assess the predictive performance in each of the measured continental ancestry, so in African, South Asian, East Asians, American, and Europeans. And then what we did also was to assess the risk conferred by single gene mutations and compare what we can do with the polygenic risk score. Because also when we add a new technology, a new risk assessment, it's super important to assess how much can we improve what is already done, how much can we improve the standard assessment. And so here, we identify that, BRCA carriers, they have like between 5 and 6 times the increased risk compared to the non-carriers. And then there are also the moderate impact genes that are all those genes that have like moderate impact. So they have like, between 2 and 3 increased risk, and also the low impact variants. And then we assess how well polygenic risk score can identify the women at increased risk. And what we found is that if we take only the 10% of the population, so remember, the polygenic risk score is normally distributed. So if we take like the 10%, top 10% of this tail, we identify women who have the same risk of carriers of low impact mutation. So even greater, the low impact they have around between 1.7 and 179. Here we can identify 2 to 2.9, but are 40 times more common in nature because, mutation are extremely rare. So we can identify 40 times more women with equivalent risk of the monogenic mutation. And then if we go like farther down towards the end of the tail of the distribution, we can identify individuals in the top 5% of the distribution who have 2 to 3-fold increased risk, so equivalent to moderate impact mutation, but are 20 times more common. And then if we go even farther down to the tail of the distribution, we identify the 0.5% individuals with the same risk of BRCA2 carriers, but are 2 times more common. So this means that with this approach, with this solution, using polygenic risk score, we can identify much more women at increased risk who are completely missed by the standard risk assessment. And then we can also use polygenic risk score to modulate the penetrance, to identify the accurate penetrance of single gene mutation carriers. So penetrance is like, is the risk conferred by a single gene mutation. So it's like, how many women, for example, with that mutation will manifest the disease. And now this is a very important example because these are all carriers of CHEK2 mutation for which the clinical management is not really straightforward because they have around 20% lifetime risk. But then if we stratify further these women based on their polygenic risk score, we can identify around 50% above the 20% lifetime risk. So this is the lifetime risk threshold to start, the MRI, so to be like, kind of, an active surveillance, and 50% below the risk. So this really help in identifying the real accurate risk even in carriers. And so we can pack all together in a test, in a diagnostic test that can not only assess the monogenic mutation, but also the polygenic to really have this comprehensive risk assessment. And then what we can do also with PRS is to identify when a woman has the same risk of a 40-year-old woman. Why 40-year-old? Because 40 is the age threshold to where the guidelines recommend to start the mammogram. So where there is if you think about an opportunity to catch the cancer early, because before the age of 40 without mammogram, there is no an opportunity to really catch the cancer as early as possible. So with polygenic risk score, we can stratify. So here each line is a different score. We can stratify the population, identify women who have equivalent risk of a 40-year-old, so but even 10 years earlier. So there is no reason why this woman should wait 40 to start the mammogram. So this woman should start mammogram at their 30. So it's really a way to personalize this approach of screening. And then also for women with the high breast density, where we know that the polygenic risk score is not really effective, we can use this model, this integrated model, such as the therapeutic, and identify those who have more than 20% lifetime risk, and also start the MRI surveillance. So this is a way to identify women among those with the high breast density that should do like more advanced imaging to detect the cancer early as possible. Then I switch now to prostate cancer, because we know that now the standard of care to assess prostate cancer risk is using this prostate-specific antigen, so the PSA, but it's not very reliable, because around 75% of elevated PSA results, so men with high PSA, they are actually false positive, so they do not have prostate cancer. And also the same is true for those who have cancer but without high PSA, so high prostate-specific antigen. So it means that 20% of cases can be missed using just this approach. So I want to show you this very interesting trial. So this is a very large clinical trial that was done in the UK, where they use this approach of using a polygenic risk score in addition to the PSA. And what they found is that the prostate cancer found only with the polygenic risk score, so found with this polygenic risk score approach, 71 among those prostate cancer found with the polygenic risk score approach, 71% they will have been missed using the traditional PSA, MRI, and then biopsy. Because now, the men with the high PSA, they can do an MRI, and then if the MRI confirm this, elevated risk based on imaging, then this can be escalated to a biopsy. But using just this approach, 71% of prostate cancer cases detected with the PRS will have been missed. So this is really an interesting study that shows how important it is to combine genetic information in a prostate cancer risk assessment. And this is so why polygenic risk score can detect this cancer, because the stratification of risk is extremely high, it's extremely strong. So here again we have the percentile, so the different scores, and here we have the lifetime probability of prostate cancer. We can see that we can go from 1% up to more than 40% lifetime risk of developing prostate cancer, so way beyond the guideline threshold. And then we can also use polygenic risk score to stratify risk, for example, in BRCA1 carrier, for which the clinical management is not really straightforward. So as you can see here in this plot, the stratification is even greater. We can really identify men with extremely high risk and men with risk below the average, but who are all carriers of this single gene mutation. Then I would like just to conclude adding a few slides on coronary artery disease polygenic risk score, so a heart attack polygenic risk score, because that cancer survivors have 30% to 300% more increased risk in developing a heart attack. And this is even, let's say, more alarmingly because around 30% of heart attack happen in patients without standard risk factors. So many many heart attacks, despite being the major cause of death in the population, they are still undetected by the traditional risk assessment. And the polygenic risk score identify men and women with more than 2- and 3-fold increased risk that are completely missed by traditional risk assessment, because we know that in heart attack prevention there are some models that can be used, some risk models, but risk models do not capture individuals at high genetic risk. So it's really important to go beyond the traditional risk assessment and use polygenic risk score to assess the risk. And this is even like more important, in cancer survivor, because there is a population with already an increased risk of a heart attack. And this slide is interesting because really show the effect of polygenic risk score combined with different levels of LDL cholesterol, because now we know that LDL cholesterol is one of the major, the driver of atherosclerotic plaque formation. So the plaques that cause heart attack, they're driven by the LDL cholesterol. And what we see here, we have different levels of polygenic risk score: low polygenic risk score, intermediate, and high, and different LDL levels, so like below 100, 100, 129. And what we can see is that people with a high polygenic risk score and LDL above 130, even 130 up to 159, they have equivalent, so actually higher risk than people with hypercholesterolemia and a normal genetic risk. So what does it mean? That people with high polygenic risk score and just like slightly elevated LDL cholesterol, that is actually a level of cholesterol that is present in the majority of the population, affect our arteries as those with who have hypercholesterolemia. So this is so important because individuals with high polygenic risk score, they can be completely undetected in a standard risk assessment because it's based primarily on LDL cholesterol and other risk factors. So we know that other risk factors do not capture this genetic component. And if you look just at your LDL, you do not see that instead this what can be considered an average LDL cholesterol instead is extremely dangerous and should be reduced with lifestyle intervention, but also with statin and lipid lowering therapies. So this is really a very strong and powerful way to assess who should be under lipid lowering therapy to prevent the heart attacks, but is completely missed. This is completely flying under the radar of current risk assessment. So thank you. I complete my presentation. I'm really happy to have any questions that you might have.
Right. Thank you very much, Dr. Botta, for very insightful and fascinating presentation. So it's very exciting to see how polygenic risk score is going to help to identify risk before diseases strike and how we can move from a very reactive care to a proactive prevention, which I think that is very critical. So I'm going to get us moved. I'm going to bring one question as we wait for the audience to add additional questions. Would you mind to talk about what happens, what is the mechanism of inheritance for polygenic risk score? If I get a positive polygenic risk score, let's say for breast cancer, does that mean that that is going to be inherited to my children?
So is different compared to monogenic because monogenic there is just one mutation, but there are researchers that have studied the heritability and they found that there is 25% chance of passing a high polygenic risk score to first relatives. So it's a pretty high chance that a first relative will also have a high polygenic risk score. So like cascade screening is recommended to also in patients that they can identify if high polygenic risk score was a cause of the disease, and so they can inform family members.
Thank you very much. Brad, I see that you have some questions.
Yes, this sort of more kind of patient access questions a little bit, Giordano. What kind of biosample is used? Is it saliva? Is it blood? What drives the sample that drives the score?
Yeah, very simple cheek saliva swab. So it's simple swab inside the cheek that can collect, some cells in our cheek. So it's very easy to perform.
And how much does it cost? Is it covered by insurance?
So if some criteria are met, for example, family history and the criteria for the monogenic testing, we also add the polygenic risk score. So based on certain criteria, if the criteria are not met, so we cannot use like insurance path. So we have a self-pay model of $249, so with a financial assistance. So it's an accessible genetic test.
How would you compare your test to the 23andMe of many years ago?
Yeah. So, 23andMe, they, of course, first was a consumer test. So our test, they need to be ordered by a doctor. So they're physicians initiated. They cannot be bought online. And also 23andMe, they have like, a very basic polygenic risk score. So the work that we have been doing during these years is to combine multiple data set and develop multiple new methods. And now we can identify individuals with equivalent risk of those who are already treated or are already under certain screening. So it's not a nice to have. For example, some 23andMe polygenic risk score were a nice to have because the magnitude of increasing risk was not actionable from a clinical standpoint. Instead, all our polygenic risk score they are actionable because if someone is detected a high risk, there is a clear management path to reduce the risk or detect the disease earlier.
And can the polygenic risk score be used for monitoring as well as screening?
For monitoring after, sorry, I didn't present this, but actually it's very important application because we can identify women with increased risk of contralateral breast cancer. So this can inform also, among, patients who, for example, should be prioritized for a surgical intervention or, can inform like, follow-up analysis even after the first event.
Very good. Alan, I see that you have a question here. Would you like to ask it directly?
I guess I can. The problem is I'm long-winded, so that's a very short way for me to ask the question. I am a prostate cancer patient, so I'm actually aware of, and I know it's not in the polygenics. Never mind. Let me just ask the question off the screen. You have a Gaussian distribution graph where you place polygenic scores, and you were focusing rightly at the high end to identify patients that may be at higher risk, and therefore maybe you might, for example, intensify screening procedures or do family counseling or whatever you do with that pre-disease information. I'm sorry for all that lead-in because let me just ask the question. Is there any valuable information on the lower end? Because I can tell you, for example, the Decipher test in prostate cancer actually does something on the lower end as well as the higher end. But I won't bore everybody with what Decipher score says. My question, if you can't see it, is, for example, Angelina Jolie opted to get a prophylactic bilateral mastectomy by virtue of not her having cancer, but her having a genetic score that suggested, specifically a monogenic score. Now to my question. I'm sorry. See, I'm long-winded. My question is, is there any information on the lower end? Like, for example, let's say I were a person, let's say I'm a woman, and I'm very concerned, I'm super frightened about breast cancer, and I'll do whatever it takes so that I don't get breast cancer. And then on a monogenic test, I'm told that I have a moderate risk, and I'm going to get a prophylactic bilateral mastectomy. But you guys do your polygenic score, and it shows that they're on the lower end. Would you be able to counsel a patient, hey, your risk is not as high as you think it is?
Exactly. This is especially important in carriers of monogenic mutation. Maybe I can pull again one slide so I can show you that the stratification of risk is really important, and they use also to assess when, for example, a certain intervention such as a mastectomy should be performed, because there are some women that maybe they want to conceive, they want to have a child, they want to breastfeed, and so with with PRS we can identify if when the risk, a certain risk that is like considered to be important and dangerous is reached. So maybe this woman can reach like the risk instead of in her like 30s or 40s in their 50s, and so the mastectomy can be delayed in that circumstances. And
You may not be on the clinical side, but I'm curious, do you have an anecdote or do you know of cases where a patient is opting to do a prophylactic bilateral mastectomy and by virtue of your polygenic score decides not to? Do you know if that's actually operational today?
Yeah, there are several, doctors that use it also to really to inform exactly what you just said, that, they in carriers of, for example, on BRCA, they use polygenic risk score to inform, their surgical, intervention. Yeah, so yeah, this is already used in this regard.
Do you have an idea of what the penetrance with clinicians is in the United States for that specific use?
Yeah, no, I can say that everything started like around like a year ago, so it's not like widespread. So we are doing like a lot of work on educating and try to inform. But now there are like just a handful of clinicians that are already using it in this way. Yeah, so it's really starting now.
Thank
So
you very much. Any other question, Alan?
No, I want everybody to know a timetable, and the timetable is something that's been in existence for 20 years, something that's been in existence for 2 years, and something that's on the cusp and something that's emerging. It sounds like I'm not following this space. It sounds like it's just emerging. Do you have other competitors, and are they more advanced than you are? Or are you the most advanced company in this space?
Yeah, I can tell that we are the most advanced. That is really an emerging technology, and we are because there are different disease areas that this technology can really help, and it's difficult like to really inform like all different stakeholders, different physicians. So what we are seeing that we were working with the key opinion leaders. This is what we can really accelerate adoption, because key opinion leaders are doctors that they have the time and to learn more, go to conferences and read more and more papers, and so then they can inform others. But yes, especially like the use of PRS in carriers. This is really a new concept. Because the validations of this course were possible just because of these very large prospective biobanks. So now that we have validation in multiple ancestries, not only Europeans, because also a big problem before was the overrepresentation of European individuals. So now that we have this the diverse data set and the validation, now is possible, but education is not completely fully enrolled. Actually, it's really starting now.
Thank you very much. So let's move to Michael. I see that you have several questions, Michael. Do you want to ask them directly?
Yeah. Yes, thank you. Thanks for the presentation. Just by way of background, to expand upon what Brad said, I was the director of a Department of Defense Breast Cancer Center working with Walter Reed, where we did everything from surgery back. And I worked on the original development of the HER2/neu test before we actually had Herceptin. So I've been involved in breast cancer work for quite a while. And we're actually building models of how women in a nonprofit progress over time in development, starting with puberty, in a personalized track through perimenopause, and then have individualized breast cancer risk. So we're looking at the problem after the initial genomic analysis. Some of the questions I have are involved in things like you referenced the Tyler-Cuzick risk algorithm. We found significant problems with that. The two major issues that you have with that is one of the scoring elements there is the occurrence of a breast biopsy, positive or negative. In 20 years of study and surveying women, I've never found a woman who volunteered to have a breast biopsy who was not at risk for breast cancer. And so there's a bias in that algorithm. The second is the number of relatives who have breast cancer. And the reality, as you're pointing out to a certain extent, is it's not the number of women who have breast cancer, because it should be the subtype of breast cancer that they have. Because as you noted, most of the breast cancers are not directly inheritable, and the skewing of the algorithm to look at risk when you count all breast cancers, again, overestimates the breast cancer risk because of that. So those are just 2 points to add into what you're doing. The other, just to pick up the discussion you were having with Alan, again, from what we were involved in, starting in the surgical side as well, one point just to keep in mind, while women have had prophylactic bilateral mastectomies, that actually does not remove your risk for breast cancer, because the breast tissue is attached to this chest wall, and it's impossible to remove all of the breast tissue. And unfortunately, there are a not insignificant number of women who have gone through that procedure and still come down with breast cancer later on. So those are just several observations.
Yeah, well, I think that at that regard, I'm sorry, I'm jumping here as breast cancer survivor. I think that that's a very personal decision for patients.
Yeah.
I can tell you that, and I suppose that also the amount of tissue also plays a role. But I think that is very personal as well. I just wanted to add that part, since we have had that conversation as well in the past. Any question, Michael, for Dr. Botta?
Yeah, I mean, I'm not sure how much dependence there is on the Tyler-Cuzick risk score. We've developed, as I said, since we're building a model, we've developed a risk score that's based purely on physiologic developmental landmarks in the woman, starting with puberty and a very detailed analysis of development, even through pregnancies. And we have a much higher predictability with that score than the Tyler or any of the other related algorithms, if you're interested.
Yeah, no, absolutely. So let's say in the last years, Tyler-Cuzick also improved, because now they has also the breast density and polygenic risk
Yeah.
score integrated. And so, like, the net reclassification improvement shows that, an improvement of, so more cases can be identified above the threshold and more controls below the threshold. But, there is like, so much to do also, like, to improve these models. But let's say, the multimodality is what, can really help, to add, additional components. What we see is that, slowly but, progressively, these models also are adding new modalities.
Well, we're actually working on a fusion of ultrasound and mammography to deal with breast density. So actually looking at a way to deal with dense breasts in an analytic method.
Very good. Thank you. So let's move on. I see, Carolina, you have a question here. Would you like to ask it?
Yeah, so I think it is related to some previous comment from Dr. Botta regarding the clinical implementation of polygenic risk scores and all the challenges that his team might have experienced with that. I have work experience in Colombia and also recently here in Canada. I was also working in a research team that was based in the clinic, in a genetic clinic. And I know that this is not really implemented on a daily basis, at least in these two settings that I have worked. So that's probably my question. And if there's anything that your company and other similar companies are actually doing to overcome these barriers. I mean, if this is actually something helpful for the patients, it needs to be implemented. That's really my question. And also regarding the can risk model and using these polygenic risk scores, this is not being added in the clinical that I was actually working here in Canada. But more than that, and I am thinking now in my Latin American peers and patients, is there something being done with the team that developed that risk model to actually take into account all the different risk factors that are more representing the Latin American women? I think it's what I'm trying to say. So it's not only that the polygenic risk score it's adapted to different ethnicities, but also if it's going to be used to complement any risk assessment in any women from any part of the world, then these other risk factors that are hormonal and gives more information also needs to be adapted, I think, to different ethnicities and ancestries and cultural differences from our ladies in the world. So that's basically. Thank you.
Yeah, absolutely. So we have performed a validation in Colombia actually, and we begin to roll out like very quickly this. So we perform this, clinical validation, integrated risk assessment, incorporating genomic and non-genomic data for psoriatic breast cancer in Colombia, and we show that the performance and validation and the improvement of the risk model. So this really to show that we really have to perform local validation. So this is like what the only thing that can really allow us to assess the performance. And we, with our approach, so with our technology that model the ancestry and also the local ancestry, so we even in admixed individuals we can identify what is the best score and the most calibrated score. We were able to provide reliable and robust polygenic risk score. And what was like the implementation question that you had at the beginning?
If just learn a little bit more about the strategies that you are doing currently, along with other companies that are dedicated to the same investigation, just to put this into practice, because I don't see that actually happening.
Yeah.
Clinicians using the polygenic risk score to make decisions. I have not seen that. So I am wondering if maybe there's a place in the world where that is actually happening and I just don't know, or if there are more challenges that you are trying to overcome with that regard.
Yeah. I can say like here in the US is like really growing, but also Europe and another part of the world. But it's not the standard of care. So this is like the main problem. So the only doctors that are informed, that or they are these key opinion leaders, or they talk or they attend some conferences, or they start understanding the value, and then they can offer the Discord, they can use it. And also what is very important is now that both the therapeutic and the can risk, they accept so the integration of polygenic risk score. So now you can use these models with the polygenic risk score integrated. It's not straightforward to do if you do not have like the right tool. In fact, what we do to improve accessibility and adoption is to provide doctors with an integrated model that they can like perform all this analysis, and then they have the output, so they have the report considering all of this. But the technology is there, validation have been performed. These risk models, they accept the integration of polygenic risk score. Is all about educating physicians and that this is available, and they can identify women who are otherwise just completely missed by the risk assessment, who are actually at high risk.
I would like to follow up on that, Giordano. So if, individuals around the world, let's say Latin America, want to have access to allelic tests, is that possible? What would be the path to do that?
Yeah, it will be through shipping samples in the US, and we have also worked with different laboratories. So it will be very. So it depends on the country, but it is possible to perform the test even in the US.
Very good. Awesome. I see another question from Royce. Did I understand you to say that patients with a higher risk score for cancer have a higher risk of arteriosclerosis at lower LDL levels? I think this was related to heart disease.
Yeah, exactly. So in general, cancer patients, so after the event, they are at a higher risk of a heart attack. And so then polygenic risk score for a heart attack. So this is a different polygenic risk score. It's not polygenic risk score for breast or prostate cancer. It's a polygenic risk score for a heart attack. And this can be applied to cancer patients to identify who should be under lipid lowering therapy, because they not only have the increased risk because of the cancer, but they also have this increased risk because of their genetics. So combining these two is really so important to start a lipid lowering therapy to reduce the LDL cholesterol, because even with no normal LDL cholesterol, they are at extremely high risk. So they have the same risk of those with extremely high LDL cholesterol, even if their cholesterol is normal.
Thank you. Any other comment or question from the audience?
Just following up on that is I was actually going down this path to get a statin myself, coincidentally. And they recommended one of my cardiologist friends recommended an LPA test. Is that the gene that is correlated?
Is a orthogonal, so it's completely different. It's not the gene, because the gene is one gene is this lipoprotein A, but then we look at around between 500,000 to 1 million variants based on the ancestry. So this is a really polygenic component, but the increasing risk is higher than lipoprotein A. So now lipoprotein A is gaining traction among cardiologists because increase the risk by twofold. But high polygenic risk score increase the risk from twofold to threefold. So it's really important to consider both.
Okay, so I should, in addition to asking for a calcium test and a LPA test, I should ask for a polygenic risk score.
Exactly. And then I suggest also to do not rely too much on calcium score, because it looks at the calcified plaques. Instead, what is much better to do is a CT angiography, because you can detect the soft plaques. This is not invasive. There are companies such as Clearly that they do apply AI to the imaging and then you can really see the dangerous plaques, because the calcified plaques are actually more stable. And also individuals with zero calcium score, they can have the soft plaques that are the dangerous one, especially those with high PRS.
Could you repeat, please, Giordano, what is the name of that test to identify the soft plaques? I know that this is cancer, but I think that that's highly relevant for everybody here as well.
So CT angiography and is the imaging technique, and Clearly, CLEERLEY is the company that analyzes the imaging with the AI to really identify all the different plaques, and especially those that are extremely dangerous. And so now lipoprotein A and CAD polygenic risk score are the two most important components, together with FH. FH is this mutation in the for familial hypercholesterolemia, but familial hypercholesterolemia is very rare. Instead, the polygenic risk score identifies individuals who have the same risk but are much more abundant in nature.
Very good. So we are almost hitting the hour. I would like to ask you, well, closing reflection, Giordano, if you could leave our audience with one key message about polygenic risk score and cancer prevention, what that would be?
Yeah, that the cancers are really complex diseases, and they cannot be let's say explained or captured. The risk cannot be captured just what is a single gene mutation, because there is a very complex metabolic cascade, and so we need to use this polygenic approach to really capture the entire polygenicity, so the entire complexity of this mechanism.
Thank you very much. And actually, I see another question here from Rick. If you are getting a prostate cancer PRS, which one would you choose?
Yeah, we develop our own polygenic risk score, so that are multi ancestry, and that they outperform any polygenic risk score that is has been developed before. So we did the benchmarking. So the polygenic risk score that we offer are multi ancestry. It means that we perform first a genetic ancestry analysis under the hood. So we start first from the saliva sample to assess the genetic ancestry of the individual. For example, if he's a mixed or if he's a 100% African, for example, and then we apply the correct polygenic risk score, so the most appropriate polygenic risk score for that genetic background. So we have like multiple polygenic risk score for a different ancestry, because they have different genetic components, and so we select the best PRS based on the genetic ancestry analysis.
Thank you. And our last question from Allen. Can this polygenic risk score test be used in someone with established cancer to intensify monitoring or treatment in the adjuvant setting, post-curative attempt treatment?
Yeah, there for breast cancer, for to assess the risk of contralateral breast cancer, we develop a PRS that is specific for that. But for therapies and others, like there are, for example, other modalities like also the MRD, so minimal residual disease, that assess the presence of cancer cells, even at very small component, that they look at the somatic part of the genome. Instead, we look at the germline, that is what is fixed from birth.
Very good. Well, thank you very much. I think that is